Hello, everybody, and welcome. I first want to apologize. Unfortunately, there was a system-wide error with Zoom 5 minutes before our webinar was due to launch, which made it impossible to launch the webinar. So I apologize for anybody who tried to join us on live for the live session. But thankfully, Megan was able to record the session for us today and that you're still able to participate. So thank you, Megan, for that. I just want to welcome everybody to the session for today. It's a joint session between the CLPNNL and the NLCHP on cultural safety in healthcare information for health professionals. And our presenter is Megan Hudson, registered nurse. I'm Janine O'Malley, and I'm the Deputy Registrar at the NLCHP, and joining us from the CLPNNL is Wanda Squires, practice consultant. We're going to help moderate we were going to help moderate the session today, but we don't have any participants, so we're just going to enjoy listening to Megan's presentation. So before we get started, I just wanted to acknowledge that today is National Indigenous People Day. National Indigenous Peoples Day is celebrated every June 21st on the summer solstice as a day to recognize and celebrate Indigenous cultures across Canada. For generations, many Indigenous peoples and communities have celebrated their culture and heritage on or near this day due to the significance of the summer solstice as the longest day of the year. We'd also like to acknowledge that the lands from which we are virtually joining today are from the traditional territories of diverse Indigenous groups, and we acknowledge with respect the diverse histories and cultures of the Beothuk, the Mi'kmaq, the Innu, and the Inuit of the province, and we strive for respectful relationships with all the people of this province as we search for collective healing, true reconciliation, and honor this land today. Now I'd like to take a minute just to introduce our guest speaker today. Megan attained her Bachelor of Nursing degree from Memorial University and has been practicing as a registered nurse for more than 10 years. Megan has practiced primarily in community health and acute care dialysis, and currently works as a tuberculosis nurse. Megan completed her master's in nursing with a focus on teaching at Athabasca University and maintains community health nursing certification with Canadian Nurses Association since 2013. Megan attributes her strong sense of community and connection to her Indigenous culture to her upbringing in a close-knit community on the coast of Labrador. Megan is passionate about working with communities to strengthen self-determination in health and wellness. Megan is an advocate for continuing education and works with interdisciplinary teams to improve the delivery of culturally safe care. Megan currently serves as a member with the Council of the College of Registered Nurses of Newfoundland and Labrador and volunteers her time with many community projects and organizations. Megan is a proud foster parent and dog lover, and Megan currently lives in Nain, Labrador with her husband and 2 dogs and enjoys traveling, camping, and kayaking. Welcome, Megan, and thank you for presenting for us today and for your patience. So I'll hand it over to Megan now.
Megan, you're muted there.
Oh, sorry about that.
Okay.
I got a little glitch. So thank you, Wanda, and thank you, Janine, for the introduction and for allowing me to be here today to speak with your registrants. I do appreciate the land acknowledgement, and it is, I think when we planned this date initially, I didn't realize that it was falling on National Indigenous Peoples Day until I was working on my slides a few days ago. So it's very fitting that it falls on this day as well. So welcome everybody virtually who will be watching and listening afterward, and thank you for attending. Okay, so hopefully my slides are working there. So our topic today is cultural safety in healthcare, and it's information for healthcare professionals. Sorry there, I'm just having a little issue with my slide. There we go. All right, so Janine did offer a land acknowledgement. I guess she did mention the various diverse groups of Indigenous peoples across our province of Newfoundland and Labrador. And I would like just to point that out on our map here as well of the province, and just make note to the, the vast region that we cover in the province, but also the areas that, primarily most Indigenous peoples live and reside within the province. So within, we'll start with Northern Labrador, so Nain down as far as Rigolet. That is the land claims area for the Nunasiavut Inuit. There in Central Labrador, Sheshatshiu is not on the map, but it's there next to Northwest River, as well as Natrashish on the north coast. That's the Innu First Nations group of our province. In Southern Labrador, so from the Cartwright area south, we have the Inuit of Nunatuavut. And then on the western portion of the island, we have the Mi'kmaq First Nations group there. So we are very spread out, and certainly are mostly living along the coastal areas of our province. So before we dive into cultural safety and, and what that is and how we apply it in healthcare, I did just want to look at some historical notes, some pieces of Indigenous history that certainly relate to healthcare delivery and accessibility for Indigenous peoples in this province, but also throughout Canada. I will say that we did offer a similar presentation with some other colleagues as well back in February of this year with the in collaboration with the College of Registered Nurses, the College of Licensed Practical Nurses, and the College of Social Workers. So for some of you who may be on the line from the College of Licensed Practical Nurses, you may have seen a presentation with myself and some colleagues back in February from multiple disciplines. So I apologize in advance if some of this is a repeat for you, but hopefully it is a good refresh and hopefully information that you can continue to share with your colleagues, and hopefully information that will be beneficial in your practice. So looking at Indigenous peoples and colonization. So when we think about cultural safety today and the role of cultural safety in healthcare, we really have to be able to understand the historical piece around Indigenous peoples and their encounters with the healthcare system historically, and why there is such a need for focus on culturally safe practice at this present time. So historically, the arrival of the Europeans in the province, was the first point of contact and where we can say colonization began. So before contact with Europeans, Indigenous peoples in Newfoundland and Labrador had adapted to their environments, and they lived in balance with the land. Infectious diseases that were common in Europe, such as tuberculosis, cholera, smallpox, measles, and influenza, were absent in Indigenous communities. They didn't exist here prior to the arrival of Europeans. So contact with the Europeans completely disrupted this balance and impacted the health and well-being of Indigenous peoples drastically. Indigenous healers who held centuries of knowledge about local healing relevant to their own people did not have experience with treating European diseases. So out of necessity, Indigenous peoples turned to Western medicine to combat Western diseases. Before the 20th century, people living in rural and remote areas of the province had very little access to healthcare and social services. In Northern Labrador, for example, limited healthcare services were provided by the Moravian Mission, mostly in the form of European medicines and first aid. And often the Newfoundland government sent a physician along the coast of Labrador to visit the communities. And there was usually, a physician arrived on a boat, visited the community, saw people, and left again. So historically, there was never a continuity of care. There was that drop in, here you go, this is what's wrong, see you later. That continuity of care that we strive for now, and building that rapport and that relationship with our clients and our communities, that was not a reality years ago, and even not so far in the distant past. So relocation was also an issue when it came to a period of colonization. So lots of individuals and families were relocated due to diseases such as tuberculosis, for example, which is an area that I currently work in. Relocation due to this ended up with individuals and families being relocated from their coastal communities to sanatoria in other areas of Labrador, and sometimes on the island as well in St. Anthony area. I have co-workers that have shared experiences with me about their TB diagnoses in the past. I have a co-worker who is not very old, who is in their 60s, and shared that when they were about 3 years old, they were diagnosed with tuberculosis. So there was a ship that came through the Labrador coast, came into each of the communities. People were boarded onto the boat one by one. They had chest x-rays, they had checkups with a physician. If it was determined that they had tuberculosis, they were taken. They were taken away from their community, taken away from their families, their culture, their language, everything that they knew to be home and safe was taken away because they were given a diagnosis of a disease that they had no idea what it was. So this individual in particular had left the community and went to sanatoria for over 2 years. At that time, when the individual returned to her community at the age of 5, they were no longer able to speak their native language of Inuktitut. Their parents could only speak Inuktitut, so they came home and were now fluent in English and were living in a home where nobody else could speak English with them, and they couldn't communicate with their parents after not seeing them for 2 full years. You know, when I think about the impact of that, of being a toddler, a 3-year-old, and being taken away from your home for 2 years and having no contact with your family, and returning and not being able to communicate with them because you now speak a different language, I think that's just one of the most profound, examples of impacts of colonization and the impacts of healthcare that was provided to Indigenous peoples during that time. So one of the main colonial structures that has historically impacted Indigenous populations in Canada is the residential school system, which in very recent years and months we've heard a lot more about. A federal government initiative which removed over 150,000 Indigenous children from their communities over a 130-year period in an effort to assimilate into mainstream Canadian culture. In Newfoundland and Labrador, residential schools existed in 6 communities, 5 of which were in Labrador and 1 in St. Anthony on the island portion of the province. The last residential school in the province closed in Northwest River in 1980. So just over 40 years ago, the last residential school in our province was still open and children were still being boarded there. So again, many Indigenous children, they lost their language, they were denied their cultures and autonomy, and they were bullied and abused for being different, for looking different, for speaking different, for being different from everybody else. The separation from their families caused damaging intergenerational social disconnect. I'd like to share a quote from a book by Andrea Proctor, who's a researcher. She recently published a book called A Long Journey, Residential Schools in Labrador and Newfoundland. It's a fabulous book. And if you're certainly interested in learning more about residential schools in our province, it's an excellent read. And Andrea writes that children were forced to live in institutions premised on their cultural deficiencies and designed to radically transform them. As a result, shame, guilt, and memories of racism and abuse caused deep pain and sometimes fueled addictive or self-destructive behaviors. And that's where we talk about intergenerational trauma and how those traumas are passed in between generations, and how that's very much alive and well today amongst Indigenous populations. And so understanding this history about what has happened to Indigenous peoples and not at their own will, for sure, has drastically impacted what we see today in our healthcare system because of a lot of mistrust and a lot of due to past experiences within our healthcare system and with the government. So the Truth and Reconciliation Commission, in 2008, the TRC of Canada was established in order to document the history and the impacts of this system. The TRC has since released its final report and its calls to actions. And I think that in recent years, these have been widely spoken about as well in the media, the news, and hopefully within our own workspaces as it relates to our patient care. So the Truth and Reconciliation Commission provided those affected by the legacy of the residential school systems with an opportunity to tell their stories and experiences. They spent 6 years traveling to all parts of Canada and heard from more than 6,000 witnesses. And in December 2015, the TRC released its 6-volume final report. As a part of this final report, the TRC outlined 94 calls to action, and some of the recommendations were very specific to healthcare. And one in particular call to action was to provide culturally competent care or competency training, for all healthcare professionals. And so based on that call to action, across healthcare organizations, across governing bodies such as the NLCHP and the CLP and NL are making efforts to offer information sessions such as these and other educational opportunities for various disciplines and practitioners to become more aware of cultural diversity and to learn how to get to a space of cultural safety and being able to provide culturally safe care. So here's just a little photo of one of the summaries of the final report. The links are here as well. So the National Center for Truth and Reconciliation and the reports, you can Google them, easily find them online. The TRC made a comment as well that every healthcare provider should read this report in full or in summary to learn more about the terrible history of residential schools. This knowledge is vital for appreciating the health and healthcare needs of First Nations, Inuit, and Métis patients. Okay, and in recognizing that, there is a cultural safety course. So in response to the call to action by the TRC, the College of Physicians and Surgeons of Newfoundland and Labrador approached the Office of Professional and Education Development at the Faculty of Medicine, Memorial University, to develop an online module for Indigenous cultural competency training for physicians and surgeons, but this module is open to other health professionals as well. You can see the link up at the top. It's www.mdcme.ca. I had gone in and done the course. It was very easy. I think at one point you did have to pay a fee to do it, and now that's not in place. So last week, for example, I went in and logged in. I went to the website. I created an account, which took about 1 or 2 minutes, and then I was able to access this course. So it's very nicely laid out. You can access all the modules individually, and it's self-directed learning. You can take your time and go through it. So the Office of Professional and Education Development engaged with Faculty of Medicine's Aboriginal Health Initiative Advisory Board, and this included members of various Indigenous communities within the province. So two committees were established to guide the process, and this providing input into the module content was then to verify that they would be offering and would meet the competency requirements of healthcare practitioners. So having that input from Indigenous peoples and Indigenous leaders and communities throughout our province is so important. You may hear in a lot of things written now with regards to Indigenous health and also Indigenous rights is nothing about us without us. And that is so important in everything that we do with regards to providing care for our Indigenous populations, is that we don't make assumptions and that we don't choose what is best for them. They choose what is best for them, and we will try our best to incorporate that in a way that is culturally safe into their healthcare plan. So the following perspectives are generalizations, and therefore it's best to think of these points on a continuum rather than a discrete categorization. And while these viewpoints are attributed to Indigenous and Western European peoples. There are variations in perspectives, of course, and not all Indigenous people may adhere to the Indigenous views that are indicated here. And this is also true for Western and European cultures. So just to give a little bit of an idea of how somebody who is an Indigenous person who is walking into the healthcare system may view overall health and well-being compared to the healthcare practitioner who may have been born and raised into a Western European culture, but who was also probably trained in Western European culture and in that type of medicine. So again, broad perspective, but Indigenous views may be broad and focus much more on well-being as opposed to just being disease-free. Holistic, considering body, mind, emotions, and spirit, that spiritual aspect being very important for some Indigenous peoples and groups. And health overall being a journey as opposed to a destination, as opposed to just finding a diagnosis or an answer. Health is oftentimes viewed as, you know, your journey through life. It's also more communal than individualized. A lot of Indigenous groups and peoples, community is very important. A sense of community and working together is extremely important, and it's an important part of their culture. So sometimes this may mean that you may see a communal effort on a particular disease or outreach, but it may also mean that when an individual shows up to a healthcare center to receive care, that multiple people or family members are coming along with them. Because it is culturally appropriate for them to have those people with them, to have those supports with them, and for those people to be included in their healthcare plan. Because for them, maybe healing means that I need all of these people in my circle, and each person has a part to play in my healing and in my health and well-being. So moving into some terms about cultural safety, one of the main things that I wanted to point out was 5 different terms here, and we'll go through all of them because in a lot of settings, I do find that there's lots of confusion now in the literature about the terminology, and they're often used interchangeably or synonymously. And it is really important to understand the difference between the various terms and how those terms actually are interrelated and connect along a continuum of cultural competence. So I really like this this small infographic here that I did borrow it from the cultural competency course that I mentioned earlier through Faculty of Medicine. So it really gives a great idea of how these terms interconnect, what each mean, and how basically all of them build up to getting to the point of being culturally safe. So you can see in this little diagram that from stage 1 to 4, the focus is on the observer, what they need to be aware of, and to act upon when providing care for a patient, and the observer being ourselves, the healthcare providers. In stage 5, though, the focus is no longer on the observer, but on the observed. It's on the patient. In other words, the lens is now shifted to the patient to learn how they felt about the experience as they were receiving medical treatment. So that's how cultural safety is defined and how it's attained. It's that it's not about what we feel is culturally safe as providers. It's about, did that patient, did that family feel that the interaction and the care that they received was culturally safe? So cultural awareness is the initial stage that you'll see down there as stage 1. And in this stage, you're observing and you're being conscious of similarities and contrasts between cultural groups and understanding the way in which this may shape your approach to patients from cultures that are different from your own. And I like that this includes a little reflection question as well under each one to sort of get you thinking about really what are the differences between each of these terms, and how thinking about these terms and these reflective questions get you to a point of really understanding cultural safety. So how are others the same or different from me? Next, in stage 2, cultural sensitivity, You're becoming more aware and understanding the characteristic values and perceptions of your own culture and the way that in which that they may shape your approach to patients from cultures that are different than your own. So cultural sensitivity essentially means understanding if and how your actions, your beliefs might be insensitive to others. So the term and the goal is a narrow one: avoidance of blatant discrimination. So at this point, it's very low level, at the point where we just want to ensure that there's no discrimination, that regardless of what our personal values and beliefs are, that we are not going to let that impact the care that we provide to clients. Next on the continuum is cultural competence, and it's a broader term. It encompasses awareness of the impact of the clinician's own cultural identity on patients. It's knowledge of the language and cultural background of patients and families, and skills for working with various groups. This stage embraces attitudes, knowledge, and skills of various health providers, and necessary to become effective healthcare providers for patients from diverse backgrounds. So competence requires a blend of knowledge and conviction, plus a capacity for action. So it's not just about knowing the information to be competent, it's about, a conviction and your ability to act on that. It's impossible for us to be competent in everyone else's culture and to know essentially what cultural norms are for everybody. Even people within the same cultural group or Indigenous group, for example, may not share all of the same practices, values, or belief systems. So that's why it's so important that regardless of where we are on this continuum, the center of it is the patient, and this at the very center is getting to know that individual, because regardless of their culture, they are still an individual, and we can't use stereotypes or base their care specifically on thinking they belong to this culture or this Indigenous group, so we have to do X, Y, and Z. It's still important to consider the individual. Next, with cultural humility at stage 4, the stage of competency has been recently introduced in the literature. And according to Ward, Branch, and Friedkin, cultural humility is an approach to healthcare based on humble acknowledgement of oneself as a learner when it comes to understanding a person's experience. So the best way to practice cultural humility is through self-reflection exercises, which may include reflective journaling. It could mean debrief sessions and conversations with colleagues in your workplace. And we will look to more examples of that later in the presentation. And finally, at the end of the continuum, stage 5 is cultural safety. And in this final step, you're able to step beyond cultural sensitivity, that being accepting of difference, as well as competence and humility, to arrive at a place where you understand that there are power imbalances and possible institutional discrimination that derive from historical pieces that we mentioned earlier, such as colonization, residential schools. So it implies that the healthcare provider has reflected on their own identity and the perceptions that others from their cultures may hold. Culturally safe practice implies the ability to keep these differing perspectives in mind while treating the person as a worthy individual and worthy of respect in their own right. So for example, I thought here, think of a time when a specific organizational policy, a procedure, or an approach to care felt inappropriate. This may take a while. This may not pop into your head immediately, but we've probably all had those situations where we felt uncomfortable in a certain situation with a client and felt like, this is what I normally do in this sort of situation, but it's not really fitting for this client. Is that approach exclusive rather than inclusive for that client based on, cultural preferences or beliefs? And I think it's those moments that are really important. We may not do everything perfectly the first or the second or third time. I think the key there is that we learn from each experience when interacting with clients from various cultural backgrounds, that we learn from those experiences and reflect on it and bring something bring something positive to our next interaction. Okay, so here, cultural safety in healthcare. I've used this one in a previous presentation as well. I always like using this iceberg picture to really, I guess, get at the grit of cultural safety, and how what we really see is very little. It's what's above the surface, and that there's so much beneath the surface and is historical that we don't see. So the iceberg being a visual representation of many factors that impact cultural safety in healthcare. On the surface, there are factors that we observe in our everyday practice. And I'm sure that we can all recall instances where we observe stereotyping in the workplace, stereotypes based on where a patient or a client lives or calls home, the color of their skin, the language they speak, and so on. You may have overheard a coworker making a comment about a particular client as they entered the unit or the office. Sometimes we find ourselves thinking or expressing those comments based on preconceived biases. Think of a situation where you witnessed stereotyping in your workplace. It may have made you feel uncomfortable, and perhaps you felt that it's not fair just to judge someone that you have not even met yet. In most cases, we probably do not challenge those internal feelings or a seemingly simple comment made by a colleague. We move forward and begin to provide patient care. What we may not realize, though, is the impact that a seemingly simple comment or stereotype has on that client and their family. The impact on building rapport and trust, and the impact on the care provided and health outcomes for that individual. So let's think deeper and consider the stereotypes that we witness. Think of how this bias impacted or could have impacted the procedure of care, the differential treatment that was provided, the inability to develop a therapeutic relationship due to a hostile care environment, or the lack of culturally safe care provided because we or a colleague were providing care based on bias and maybe preconceived understanding of who the patient was, why they acted a particular way, and why they needed to regain health and wellness. And it's okay to admit that we've all been there. We've all been there, regardless of where we work. I know some of you who will be watching today work in private offices and practices, and you may not have colleagues in your office on a daily basis that you get to interact with and bounce ideas off of and learn with. And I think that's where this self-directed learning and partaking in information sessions and courses, such as the one mentioned earlier, are so important because not all of us are in that realm every day of getting to feed off information and learning from other colleagues around us. So we all hold unconscious bias, and when we reflect and challenge those biases, we dig deeper and see beyond the surface or the tip of the iceberg. So beneath the surface, consider how grooming of staff to hold biases based on years of organizational procedure. Consider a history of healthcare provision that did not explicitly focus on the intricacies of cultural safety, as I mentioned earlier. Consider age-old policies and procedures that are generalized, that are based on Western models of medicine and care. And they don't make space, or they may not make space for cultural considerations. Regardless of the position or the role that we assume, it's so important to understand the complexities of culturally safe care. And it's vital that we look beyond the surface and think critically to identify personal, collegial, and organizational barriers to providing that holistic, culturally safe care that our clients and patients deserve. So some considerations for healthcare providers or health professionals. Within nursing, of course, I can relate, but I did, have a look through your websites and see that, each of the disciplines have their own code of ethics and their standards of practice. And I think I can say as well that all disciplines have some sort of quality control or continuing competency, continuing education programs as well for upholding their licensure. So there are certainly ways that we can incorporate that into our practice. And with the calls to action from the TRC, there are calls to action that are specific to healthcare providers are being included now in Code of Ethics and Standards of Practice that are specific to various disciplines. So self-reflection, for example, I mentioned it briefly before, but self-reflection exercises are, is so important for cultural safety. A core aspect is examining our own cultural identities and attitudes and being open-minded and flexible. Understanding our own culture and its influence on how we think, feel, and behave is hard. A good place to start is cultural safety and humility journey with self-reflection. Identifying what makes someone else different is simple, but sometimes recognizing our own culture and its influence on how we think and behave, that's much more substantial, and it takes a lot more work. So I have included what this picture here is a resource from the College of Naturopathic Physicians of BC from 2021. You can Google it as well. It's a couple of page document. It could be printed off and completed online or offline. It's a really great document. It's just a few pages, but it has some really great questions and tips for self-reflection as it relates to cultural safety and humility. And I really encourage everybody to have a look at it and share it within your workplaces. Share it with your managers, your supervisors. Share broad and wide. These conversations are so important. And of course, this is an important part of continuing competency in education programs. Not only is it counting towards hours that you need to, that you need to renew your licensure, it's also so important to make sure that we are current and that we are providing the best possible care to clients in any setting that we practice. So before I end things off, I just wanted to share a couple of examples as well from some personal practice about how cultural humility and safety that have made a difference, I feel, in my practice. So respectful communication and building trust, that goes right back to our very basics of therapeutic communication and respect and building rapport and trust with the client. It's very much it's very basic. It's not always easy, but it's at the basis of what we do as healthcare providers when we meet and interact with clients. Without that open communication, without asking open-ended questions, being open ourselves to learning and to realizing that our views may have been wrong. We aren't open to building a trusting relationship without that openness within ourselves. So that's so important. A willingness to learn about lived experiences and cultural practices. I've seen a lot of times in my practice that other healthcare professionals who may not be familiar always with working with diverse populations feel really hesitant sometimes about asking people or Indigenous peoples, for example, about their culture and about their norms, thinking it's offensive. It's not. It's a wonderful thing to be curious and to be interested and to ask questions based on a genuine interest in that individual and how that information can not only build a relationship, but also impact the care that you provide to them. Because through those interactions, through those conversations, you build trust, but maybe you also realize that it's really important for these individuals from their family or their community to be involved in their care. And maybe this is a previous experience that they had and the reason why it's been really hard to open up to you, share experience and build a trusting relationship. Sometimes that client that seems difficult or rude or non-compliant, those are the individuals that need our attention the most, because maybe it is a past experience. Maybe it's a past experience of a family member that was shared with them that has made them feel very scared walking into a healthcare setting. So it's really important to consider why people are acting, behaving, talking the way that they are, the same as we need to evaluate why we do that in those situations as well. Identifying barriers to safe and competent care, such as language. So within our Indigenous peoples in the province, English is not a first language for everybody. And, I think we easily neglect that sometimes because, yes, sure, we do speak English, but it's not everybody's first language. And it is a huge barrier for some. For some people, for example, I can speak from clients that travel from Labrador into St. John's or other areas of the province. It's a really big barrier. And a lot of people feel hesitant to even share information because they may not be sure how to say certain things in English or communicate that effectively. So it's important to be able to advocate for resources such as interpreters and Aboriginal navigators, and really hone in on those resources and advocate for them and utilize them when you're interacting with your patients. These services are there for a reason. We need to use them. And even more, we know all too well in healthcare that there are gaps. There are pieces of our system that are missing or that may be broken and need some fixing. And that's where we come in, and we have the ability to advocate for that. So again, regardless of what your position is and, where you're a frontline worker and there's a supervisor and a manager and a regional director, it doesn't matter. We all have a voice, and we all have not only the ability, but the responsibility to our clients, our license, our code of ethics, to ensure that we advocate for the best client care possible. And flexibility in care planning. Again, that's just being open to learning new things and being flexible to what our normal procedure is. Okay, normally we don't let 3 people come into the unit, but this person needs 5 there with them for a very specific reason. That's a very basic example, but it's a big, big deal in some cases. When someone may be traveling from a different area of the province and they feel alone and unable to advocate for themselves, and they are typically used to having those other supports there with them, it's a huge deal to not, sometimes for those little things to fall through the cracks. So asking people what they need is so important. And the golden rule. So the golden rule, I think many of us probably grew up hearing, was treat others as you want to be treated, where I've heard in recent years, and I love it. And I know that growing up, my mom always said it, and I know it came from a good place, but it's to treat people as they want to be treated. And I love that because it's, treating me as I want to be treated, that's based on my norms, my beliefs, my values, my culture, my upbringing. Whereas taking the time to treat someone the way they want to be treated, it takes a little bit more work, but it's also quite profound and it's extremely important. And it certainly relates here in culturally safe care. So without a doubt, the most influential, the most knowledgeable person about their care, the most knowledgeable person about how their Indigenous culture will impact their healthcare is that individual themselves. So make sure that you're reaching out to those Aboriginal navigators and other resources. If you're discharging somebody back to a community, if you're consulting with somebody in Labrador in their community, make sure that you're taking into that context. Take a few moments to learn, gosh, okay, they're in this community on the coast. They're an hour and a half away from the next health center, which may be in Goose Bay. They're delayed due to weather and they need a medevac. All of these things come into play with sometimes just being able to get to a simple medical appointment. So I think being able to consider all those things and really open our minds to understanding where our patients are coming from, meeting them where they are, and really, truly having a genuine interest in understanding who they are and why they are. So I've just included a quick couple of resources there as well. You'll see this anyway in the presentation as a recording, but these are a couple of books: The Long Journey, Residential Schools in Labrador and Newfoundland that I mentioned earlier. It's phenomenal. As well, any other resources that you wish upon request, please do reach out to me. I know unfortunately we can't do any live questions or anything during this time, but I've put my email down there at the bottom of this slide. So by all means, please feel free to email me. there's no ridiculous questions at all. And you know what, I'm learning every day too. I'm learning with each of you every single day. And this, a lot in my practice, some of this is coming from an Indigenous person and an Indigenous nurse, but I'm learning every single day. And I'm always so happy to have these conversations with people who are interested in this topic, but also in making sure that they're providing that culturally safe care. So if you want to chat, if you want to send along a question or a comment, by all means, please do. And if you don't get this jotted down from here, you can reach out to Janine or Wanda after the fact. And I so appreciate, again, for those two ladies reaching out to me and asking me to speak. It's truly an honor to share some information and knowledge with you. And I hope that it's an area of learning that you continue into the future. Thank you.
Thank you so much, Megan. I just want to take the opportunity to say your presentation was fantastic, and I think there's so many valuable takeaways for our health professional groups. We really appreciate you giving us your time today and being flexible with our technical challenges. So again, thank you both from the NLCHP and the CLPNNL for being here today, sharing your experiences and providing such thoughtful information for all our registrants.
Thank
Fantastic. Thank you.
you.